So we'll just start. I think we have now 17 of us. So let's hope more people are going to join in. And let's get Dr. Mudit back, and then
I'm already here. Yeah.
okay, sir. So I'll just introduce Dr. Mudit to everyone. Anyways, everyone must be knowing him. So he's the head of Retina Service at LVPI Hyderabad, and he has special interest in uveitis, and he's the one of the organizers of USI, which is at Hyderabad. I think so. Everyone should join in Hyderabad, and he's whatever retina little I've learned most from him only. So I think it will be a nice session, and more than anyone, I have lots of doubts. So I am going to get them cleared. So I think because sir is from LV Prasad, doesn't like to wait too long. So we start right on time. So I think
Thank you for the kind words.
we can go ahead. We are 19 now. I think we should have participation from everyone, and let's make the best use of this session and the time which sir is sparing for us. I think we can start, sir.
Yeah, we should start. I think, yeah, it's already 9:05. We'll start.
Sir. Hello, good evening, everyone. Thank you for the opportunity given to me to present the case. Today, I'm presenting a case of 26-year-old male patient with complaints of flutters. He has no associated flashes, no similar history in the past, no history of decreased vision, peripheral vision loss, no history of trauma, no history of metamorphopsia, eye pain, redness and discharge, no history of any recent ocular surgeries. No history of intake of uncooked meat or milk products, no history of weight loss or chronic cough, no history of persistent diarrhea, oral or genital ulcers, no history of skin rash, fever, vesicles of the body, no history of headache, joint pain and morning stiffness, no history of using ocular medications. An examination, vision in both eyes was 6/6, near vision was N6, lid was normal, conjunctiva was clear, cornea clear, anterior chamber was normal, iris normal, there is no neovascularization of iris, pupil was circular and reacting to light, both direct and consensual light reflex was normal, lens was clear, EOM was full and free, IOP was 15 millimeters of mercury in both eyes, gonioscopy showed open angles, and SAIC was patent in both eyes. On fundus examination, right eye, media was clear, optic disc round, pink with clear margin, CDR ratio 0.3, healthy NRR, blood vessels arising from the center of the disc, dividing dichotomously into superior and inferior arcade, perivascular sheathing and cuffing present in superior arcade. White yellow spots seen in vitreous periphery, foveal reflex was present and macula was normal. This is a fundus picture of the patient. Left eye, media clear, optic disc round, pink with clear margins, CDR ratio 0.3 and healthy NRR. Blood vessels arising from center of the disc, dividing dichotomously into superior and inferior arcade. The perivascular sheathing and cuffing present in superior arcade. White yellow spots seen in vitreous periphery. Foveal reflex was present and macula was normal. Diagnosis, both eye retinal vasculitis. Thank you.
All right. Thank you, Irene. Can we just go back?
Sir, you can take the case ahead.
Yeah. Can we just go back once to the previous slide? Yeah. No, the fundus photograph.
Yes, sir.
All right. So what we are seeing right now are both the eyes, where you can see in the image on the left, you can see one area of a confluent vasculitis, isn't it?
Yes, sir.
And in the image on the right, what you see is one area of confluent vasculitis, and then you see this vessel branching over here.
Yes, sir.
I'm sorry, superiorly and inferiorly.
Okay.
And in both those areas, you see these two areas of vasculitis or this venous cuffing, which you can see
Yes, sir.
on those dichomatous branching areas.
Okay.
Apart from that, also on the main vessel, also you see one area of vasculitis. So it
Okay,
is
sir.
evident that what you have is a vasculitis in both eyes of a patient. You got a bilateral vasculitis in a patient.
Yes, sir.
And I'm sorry, but what was the age of the patient?
Sir, 26 years.
All right. So now that brings us to the next question. Is that maybe one of you guys, anybody can answer as to what do you intend to do next for this patient? So you have got a patient whom clinically you have seen. Were there any vitreous cells on a slit lamp examination?
No, sir.
Absolutely no vitreous cells.
Sir, no.
So there are two things. I am not talking of anterior chamber cells. I am talking of retrolental vitreous cells. So did we check for that?
No, sir.
All right. So get into the habit. Lot of times this is a mistake which all of us make. In retina clinic or in clinic, we forget looking at the slit lamp properly and seeing what is happening to the retrolental cells also. So you may not have anterior segment inflammation, but you will have posterior segment inflammation. And therefore, sometimes if you see those vitreous cells, that again can be a clue to the fact that you have got an active inflammation going on. However, you need to discern between active and inactive vitreous cells. Now, that is again one thing which people sometimes end up making a mistake. So if these are active vitreous cells, you will see them floating in the eye behind the lens area. Whereas if they are old cells, they will be number one, pigmented. Number two, they will not be floating around. They will be moving with the vitreous phase. So you will see a vitreous sheet when the patient's eye moves up and down. You will see those cells moving with a vitreous phase, but not moving separately. So cells moving along with vitreous phase and being pigmented are indicator of an old cell. Cells which are freely floating in the eye are fresh active cells, which is suggestive of an active inflammation. That is one clinical clue we should look at. So let us say right now you've got a patient who has got an active vasculitis in both eyes. So what next are you planning to do now for this patient?
Anyone from audience also can take?
Yeah, I think it will be good if our audience also starts asking or basically even
Dr.
answering.
Urvi or Dr. Iris?
Anyone? And let us quickly answer. Let us not sit around silently. And it's among friends. All of us are friends here. It's a very informal discussion which Anuj has initiated. So I think we should not be hesitant. Whatever comes to your head, just blurt it out. Doesn't necessarily have to be right or wrong.
I want to say, hello, excuse me.
Oh, one person actually.
Hello.
Yeah,
Hello.
Dr. Iris.
Sir, I want to say as the patient is young, so should we go for any specific lab test like VDRL?
I think sir will come to that.
I will come to that. So the question here right now is how will you proceed? Simple question. What is the next investigation which you would like to do if you want to do that? Number one. Number two, what are the next lab investigations? So two different questions. Which next ocular investigation will you like to do if you have an access to it? Number two, which next lab investigation would you like to do if you have access to that? And then we'll come to the treatment. So whenever you see a patient in clinics, anytime for any disease, the way you move forward is number one, the history. Number two, the clinical examination. Number three, adjuvant clinical investigations. Number four, lab investigations. Based on all four of these, you arrive at a differential diagnosis and a final diagnosis, and then your treatment. That is the sequence of events for any disease which you encounter in a clinic. So you have a young patient, you have got vasculitis. Is there any other question which you would like to ask from this patient in the history? Anyone?
Dr. Snehal, Dr. Geongi, anyone? Dr. Sanup? Or Dr. Irene can answer, not an issue. So if you make it interactive, it will help you only, because sir will doubts.
Yeah. So maybe I'll start picking up people alphabetically in the order in which they are appearing on my screen. Dr. Chinmay. Chinmay, what is another question which you would like to ask this patient? Anything which comes to your head? All right. Anyway, so if nobody's answering, I'll only answer. So now India is endemic for TB. One of a very important history which we should ask our patient where we are suspecting any vasculitis is a history of exposure to anybody or a TB contact. That in itself will make your life easier. So ask your patient, number one, a history of any TB contact, number one. Then Dr. Irene in a very nicely presented history had already mentioned history of any absence of rashes, absence of any skin signs, absence of any fever. So ask for a good pertinent systemic history. As to has the patient had a weight loss in the past, any history of fever in past, any history of any skin lesions, any history of any oral or genital ulcerations, because that will basically help in narrowing down your differential diagnosis. So we have already done that. We have taken a history. What next do we do? Dr. Sanoop.
Does the patient doesn't have any clinical features suggestive of TB or confluences or anterior segment is also normal, we go ahead with the contextual angiography from the ocular investigation side.
Yeah. So the most important ocular investigations which become relevant for us in this case are number one in OCT, because OCT will help you in deciding if there is any cystoid macular edema or not, and if possible in FFA, because FFA will also give you a clue to what is happening to the peripheral vascular areas. While you're seeing two specific areas of vasculitis, what also is happening in the periphery? Do you have a perivascular leakage? What is happening to the other areas? If you see a fun-like pattern on an FFA, again it makes your diagnosis easy, because now you know probably you're dealing with a Behçet's disease. Even otherwise, the presence of a disc edema and a perivascular leakage becomes relevant, because that shows us the amount of involvement of the vascular leakage. That is if you have an access to it. Even if you do not have, we can still get away without it and start treating our patients. You do not necessarily always have to resort to investigations. A good clinical examination in itself is half of our job done. So in this case, we already have good fundus photos, good documentation. We know the kind of vasculitis which we have. So after that, we move on to the investigations which we have thought of are number one in FFA or a fluorescein angiography, number two in OCT. If an OCT shows you edema, that again makes your diagnosis easy. You know that you have also got associated inflammation. This patient will probably also need treatment for the edema which the patient will be having. Those are the lab ocular investigations. Moving on to Urvi. Urvi, question for you. What are the lab investigations which you would like to do for your patient? And why?
Hello.
Yeah.
So I would like to do basic investigations that would rule out for basically syphilis, then like TB, like Montux and all, TB gold.
Okay.
Then for
Your
chest X-ray also.
Okay. All right. So you are nearly there. So what you need to do is you've got vasculitis. All patients of uveitis ideally should be diagnosed or basically investigated for HIV and syphilis. The reason is these two are great masquerades. It will also determine the duration of treatment which you are. Now, if you want to treat your patient with steroids or immunosuppression, you need to first of all rule out HIV, because you are giving these patients steroids for some period of time.
Right, sir.
So you need to test for HIV. That is number one. All patients should be tested. All patients should be tested for syphilis. Reason is that syphilis is such a big masquerade. It can present in any form. with plephoid chororetinitis, to vasculitis, to peripheral retinitis. So in any form it can present. So syphilis, and for syphilis, the test should be ideally done is not only the non-treponemal test like VDRL, but also the treponemal test like TPHA. So get TPHA and VDRL done for all of your patients as a rule. That's what we do at least in our uveitis clinics.
Okay, sir.
These are not very costly. It just costs around 500-600 rupees to get both of them done.
Okay, sir.
Apart
And
from
so-
that, yeah, sorry.
And so for uveitis that we do usually, that is sacroiliac joint, then do we do RA factors, CRP, even
No.
that is to be done?
No. So remember, there are two set of investigations. One, which you do mandatory for all your patients. The second, which you basically tailor make for your patients.
Okay, sir.
So the mandatory ones are HIV, syphilis, TB, because it is pretty endemic in India in most cases, specifically in cases of vasculitis.
Okay, sir.
If your patient can afford, get a contrast enhanced CT chest done, not a HRCT or an X-ray. If the patient can't afford, then obviously we have no other choice but to go for an X-ray. Get a complete blood picture done for all your patients, because that is important, because sometimes your steroids in itself can cause a leukocytosis and you need to be aware of it. If the patient has got any problem with hemoglobin or for with that matter any blood dyscrasia, so occasionally even blood dyscrasias can present like that. So get a complete blood picture done. HIV, syphilis, TB, these are the mandatory ones. RA factor, sacroiliac joint, this. So RA factor and becomes important more in other connective tissue disorders if you are suspecting a vaginous, or ANCA if you are suspecting scleritis. If it's a small vessel vasculitis, again, but usually we do them if you are not finding anything or as a last resort, not initially. Similarly, X-ray sacroiliac joint becomes more important for spondyloarthropathies, but usually again you will have associated clinical features, number one. Number two, if your patient gives history of an inflammatory back pain, then again you can consider HLA-B27. But first ask the history.
Okay, sir.
And the history you have to ask is, does the patient get pain when the patient wakes up or after a period of rest? That is what inflammatory back pain is. Not pain throughout the day, but pain which occurs when the patient wakes up or with a period of rest, and which goes away when the patient is moving around. So if that is there, then think of HLA-B27 and sacroiliac joint, not otherwise.
Okay, sir.
So those are your lab investigations. And based on your lab, yeah, sorry, Anuj. You are muted. Anuj, you are muted. We can't hear you.
So what test you will consider, sir, for TB and syphilis? Like
So for syphilis, like I said, we get both the treponemal and the non-treponemal test done. So you get a TPHA as well as VDRL both done. Again, they are not costly. TPHA is a treponemal test, which will give you, which has a sensitivity and a specificity of more than 90% for syphilis. VDRL is a non-treponemal test and it helps you in monitoring the treatment. So the clinical definition of cure for syphilis is a 4-fold reduction in your VDRL titers and a clinical resolution. And based on your results, you go ahead with treating these patients. So if it is unilateral, you may probably just give them a periocular steroid. If it is bilateral, it's preferable to start treating them with steroids. And if you get your disease positive for TB, then obviously treat with for anti-tuberculosis medicines. If your CCT chest is suggestive of sarcoidosis, you treat for steroids initially. If you have got other features of connective tissue disorders like vaginous or scleritis, then you need to investigate them more systemically, get ANCA done. But can I share a PowerPoint with all of you guys?
yes, sir. I think
Show
that
you
would
some
be great.
patterns, which will probably be okay. Somebody has to stop this screen sharing. Irene, you'll have to please stop it, and then maybe I will be able to share.
Sir, I've stopped my sharing, sir.
All right, let me see if I can share now. Yeah, I think I have it with me. Just a second. Yeah, are my slides visible?
Yes, sir.
All right, so I'll just show you a few patterns of vasculitis which will make our job easier. The good part about uveitis, or for that matter, most retinal diseases, is that they follow in most cases a pattern. And if you get into the habit of identifying those patterns, then it makes your clinical judgment easier. and you do not have to resort to a huge gamut of tests. Lot of times you can get away without doing some of them. So let us not get into the definition of vasculitis. That's something which is there in books also. But what you need to remember is what are the different clinical manifestations of vasculitis. You can see these areas of peripheral ischemia, hard exudates, all of these. Also, it is important, and I think if you get time, somebody should go back and read this basic paper on vasculitis. That was a Chapel Hill consensus on nomenclature of vasculitis, where they divided them into large, medium, and small vasculitis. And most of the ocular vasculitis is usually small vessel disease. So if you look at it, basically, if you look at it, ANCA-associated small vessel vasculitis will be GPA or vaginous, then Church-Strauss. But the large vessel one will be Takayasu and giant cell arteritis, which is also something which we can sometimes encounter. But what you need to understand in terms of pattern are there is something called a skip vasculitis, where you see these skip lesions over here, and you see confluent vasculitis. This is basically how the appearance will be. You can also see something called a frosted branch angioitis, which is basically extensive perivascular areas of vasculitis. Also, one more thing is hemorrhagic vasculitis, and a lot of times you will see hemorrhagic vasculitis in virus-associated diseases and in occlusive vasculitis, and we'll come to that. One more pattern which you should learn to identify is something which is called a chiral vasculitis, where you see these small perivascular plaques, and this usually is suggestive of toxoplasmosis, but it can also sometimes occur. So what you see are these, you see these small plaques which you can see over here. This is what you will see predominantly in toxoplasmosis, but you can also see them sometimes in TB. Also occlusive vasculitis, like what you see in a Takayasu arteritis. So you can see this patient with extensive neovascularization of disc and peripheral ischemia. If you see that sort of picture, get a differential blood pressure done, send them to a physician. You probably may be the first person to diagnose that they are having a Takayasu arteritis. So you will see no perivascular exudation in these cases. Also infections. So bacterial infections, which we have already discussed, syphilis, most commonly toxoplasma, viruses, and then fungal. And I'll come to some of them. Similarly, non-infectious can be SLE, PAM, vaginous granulomatosis, masquerades like leukemia and lymphoma, and that is why it is important to get a complete blood picture done. Also, if it is a female patient, then in a young age, again, SLE also becomes an important differential. So what are the important clinical clues? Look at specific signs, and I'll come to some of them. So let me come to that. So if you see a patient who has got this diffuse synechiae over here, more importantly, subvascular pigmentation. So if you see subvascular pigmentation, that usually is very characteristic of tuberculosis. So if you see a patient with vasculitis and you see subvascular pigmentation, think of TB. If you see vasculitis with associated disc involvement, again TB or sarcoidosis. If you see some inferior granulomas which are pigmented, again tuberculosis. So rule out pulmonary involvement, rule out lymphadenopathy. Like I said, a previous history of contact with any patient who has TB becomes very important. In sarcoidosis, what you will see along with the granulomatous uveitis are these broad peripheral synechiae, number one. Number two, you will see these multiple small granulomas. So when you see these multiple small non-pigmented granulomas, that again is a clue to underlying sarcoidosis. Again, you look at systemic signs like skin involvement of erythema nodosum, subcutaneous nodules. Lot of times this patient may come with dry eyes. Also check for the renal and cardiac involvement if the patient has already got a history for that. Also look at a mobile hypopyon. So if you see a mobile hypopyon, the hypopyon moves with the movement of patient's eye. When you tilt the patient's head, you don't see extensive fibrin. You see this peripheral fern-like pattern on FFA, like what I said. Think of Behçet's, ask for a history of oral ulceration. But remember, lot of times we as a rule ask what is oral ulceration. Patient will say, "Muh mein ek baar chala hua tha." We consider that to be oral ulceration. No. Aphthous ulceration for Behçet's means having at least 2 episodes in the last 6 months of aphthous ulceration. So 2 episodes in last 6 months of oral ulcer, that is a positive history. Any history of genital ulcers, and if you see this vasculitis, get HLA B51 done. You probably are dealing with Behçet's. So if you see patient with signs of gangrene or a peripheral necrotizing scleritis, history of nasal bleed, think of Wegener's. If you see a patient who has got loss of nasal cartilage or ear cartilage, Hansen's disease or leprosy, and a relapsing polychondritis. So these are systemic clues. Takayasu we have already discussed earlier. If you see a patient with facial rashes, cutaneous lupus, oral ulcerations, alopecia, history of renal failure or lung involvement, rule out SLE. Also, if you see a patient with a combined occlusion, arterial as well as venous, again SLE needs to be ruled out. Patient gives history of abortions, lupus, anticoagulant needs to be looked at. So these are something which we have already discussed. Also, look at these peripheral areas, that is number one. And if you see, let me go back to the previous image. If you see exudates, if you see past history of a retinitis, one or two small aneurysms in the periphery at the first order vessels, then your diagnosis becomes IR1. Because you will see these small aneurysms over here which are affecting arterial bifurcations. And you see this macular star which basically shows that there was a retinitis which had occurred. Behçet's we have already seen. Remember, vasculitis with subvascular pigmentation, TB. Also, one more clue which you need to look at, if you see these areas of peripheral granularity, when you see that, think of CMV. So two clues. Number one, if you see peripheral vascular hemorrhages, granularity like what you see over here, areas of retinitis, and you do not see extensive inflammation, that means your patient is already immunocompromised, and that is why they are not able to launch an immune response. That's why I had asked you, are you seeing any vitreous cells? So if you do not see commensurate inflammation as opposed to the signs which you are seeing, clue to the fact that your patient may be immunocompromised, check for HIV. Also, if you see these confluent areas of retinitis, and before I proceed, I would probably like to acknowledge Dr. Avinash Patange, one of my mentors and teachers in Vizag, who has been kind enough to share a lot of these slides with me. So if you see these areas of peripheral retinitis, which are confluent, then that is a clue to the fact that you are dealing with ARN, acute retinal necrosis. These are patients who need to be treated with steroids and antivirals. Like I said, syphilis needs to be ruled out for all patients. So if you see this ground glass retinitis, you see these multiple small miliary lesions, then think of ocular syphilis. Patient comes with a history of fever in the past, then probably a post-fever retinitis. So you may see these areas of neurosensory detachment, localized hard exudates. You are dealing with a post-fever retinitis. Again, we have already discussed. So if you see these areas of confluent retinitis, think of ARN, acute retinal necrosis. Non-infectious vasculitis, I think, is something which we can skip in the interest of time. We have already discussed those. And I'll stop over here because I wanted to show you some of the patterns. But what you need to remember over here is also what are the next causes of vision loss in these cases. And those causes are predominantly either a macular ischemia, or number two, it can be peripheral ischemia, which will lead to neovascularization. So you need to look for subsequent developing neovascularization. Remember, neovascularization basically is the sequelae of the vasculitis which has already occurred. So vasculitis leads to peripheral ischemia, leads to peripheral neovascularization. These patients will need a laser or a sector photocoagulation. If the neovascularization progresses, then probably you may even need to do a vitrectomy or a retinal surgery if there's a peripheral traction. So that in essence is what you need to look at or keep in mind when you see these patients of vasculitis. Identify the pattern, identify the disease, treat them with steroids or anti-inflammatory agents, number one. Number two, you need to give them adjuvant therapy for whatever disease they have. If they have syphilis, you need to give appropriate antimicrobials. If they have got tuberculosis, you need to give them anti-TB medications. So these are the things which you need to do. Anuj, I hope that takes care of a lot of questions of vasculitis.
It was very extensive. So I think I'll take your time with a few questions.
Sure.
A lot of time, I think we are confused when to stop the treatment, as in, will the vasculitis, the sheathing disappear? And if we see just sheathing, should we go ahead with the treatment, or how should we proceed?
All right. So first, let me invite all of the participants to join us for the uveitis conference. Remember, this is purely a case-based conference where this time we will have no didactic lectures. We'll have extensive discussions on all aspects of uveitis, including pan-uveitis, white dot syndromes, vasculitis, with faculty discussing just cases. So it will be nice if you guys can join us on 14th, 15th, and 16th of October in Hyderabad. And coming now to the question which Anuj had. So sheathing starts regressing the moment you start treating these patients. So that extensive vasculitis which we're seeing usually goes away in 15 to 20 days or a month. But I usually keep most of these patients for at least a treatment of 1.5 to 2 months. That is number one. Number two, once the vasculitis goes away, you still have to monitor them for the sequences and the sequelae. And the sequelae can be, like I said, ischemia. So you will have peripheral occlusive arthritis leading to ischemia, leading to peripheral neovascularization. So always check for peripheral NVIs. Also check for peripheral NVE in the periphery. If there is any NVD which is developing, also keep on doing a meticulous slit lamp evaluation and see if there is any neovascularization of iris or angle which is developing.
Okay, sir. So that was nice. Anyone else in the audience? Any doubts?
Anybody, if there's any question which you want to ask, please go ahead. And I would also just take one more moment to, like I said, acknowledge some of the slides which I had
one question I want to
from
ask.
Dr. Avinash and my colleague Anamika from
Hello?
our GRV campus. Yeah, please go ahead.
Sir, one question I want to ask.
Yeah, who is this?
Dr. Iris.
Yeah, please tell me, Dr. Iris.
Sir, one thing I'm having difficulty in clinical examination. I'm unable to differentiate between sheathing and periphlebitis. So how can we differentiate clinically on fundus examination between the two?
So two things. Usually now sheathing. What are the causes of sheathing? Sheathing can even occur in hypertension. Hypertensive vasculopathy also can lead to sheathing. But what you will see in sheathing will be no other signs of inflammation. That is number one. Number two, the margins of sheathing are not as yellowish as like what you saw in the fundus photograph which we had seen. And they are not as irregular and blurry as what you see. So when you see a vasculitis or a periphlebitis, the margins are more whiter, number one. Number two, they are more fluffy or irregular. Sheathing is usually more homogeneous, more well demarcated, more sharply defined borders. That is one way of looking at it. Also, with sheathing alone, you will not see signs of inflammation. With periphlebitis and vasculitis, you will see signs of inflammation.
So one doubt, how common is vasculitis in TB?
Pretty common. If you ask me in terms of mathematically telling you how much common it is, I'm sorry, I don't have the exact figure, but we pretty commonly see TB vasculitis. Who was this?
And hello,
Yeah.
sir.
Yeah, you can introduce yourself and then ask the question.
Yeah, I would like to know who is this and where are you from?
Sir, I'm Dr. Sanu from Salem.
All right. Yes, Anu, please tell me.
And sir, when we start this steroids for vasculitis in TB, are we not concerned about the systemic part of TB? Because the
Are we not concerned about?
systemic part of TB and the TB will get flare up, no sir, when we start the steroids for the vasculitis?
No, you should not. See, what is happening is that you are also giving an appropriate antimicrobial cover. For any infective disease, if you are giving the steroids under a cover of the appropriate antimicrobial, you are safe. Problem occurs when we give steroids without an appropriate antimicrobial cover. And even in TB, sometimes you do need steroids, not only for ocular, but even otherwise. If you have got signs of neurological manifestations, if you have got edema over there, you end up giving steroids. Even anywhere else, if you have got inflammation, you will probably need steroids. And you are not giving them protracted long-term steroids in a very heavy dose for you to have a flare-up or you to be worried about. So while you need to give these steroids, but under the cover of ATT.
Thank you, sir. Thank you.
Do we have any other questions?
If not, then I'll stop my sharing and I'll thank everyone. Thank you so much, Anuj. Anuj, it was really nice to be with all of you. And I think it's a very good initiative and a very nice platform for us to discuss our cases. And I'll be more than happy to join you guys again whenever you want me to join.
Definitely, sir. And this is other Zoom session just maybe half an hour back, and he was back with us. So thank you, sir, to spare time. And it was really informative.
Thank you, sir.
And
Thank you for
the
the clarity.
videos, the photos were also very nice. And you shared your presentation. That also helped a lot of us, at least me. So uvea, even retina is your this. So we will definitely be meeting again.
All right. Thank you so much. Have a
So
great
I think we can sign out, sir, and we'll meet again. If
Yeah.
anyone has anything last, they can just. Yeah. Dr. Urvi Wag, do you have anything else?
Urvi,
Okay.
it will be difficult to share the images because these are not mine, all of them.
Okay,
So,
sir. Okay, sir.
yeah, I would be glad to share my fundus images, but some of them are actually, some of my other colleagues have been very kind enough to share the images with me. And therefore, probably it will be a bit difficult, but we will be coming out with a lot of vasculitis images. And two more things, there is also an LVPI uveitis course which has been started for fellows and residents, which also you can avail of. And in that, doc mode has got those classes which are available. So that can be taken care of otherwise. And we will be able to share some other images in future. I can share my images with you. I don't have a problem. And
Sure,
but
sir,
some of these images are not my own, and I have taken them from some of my colleagues, so there will be a bit of a problem.
Okay, sir. No problem.
Right? Yeah.
Thank you, sir.
Also, just one more point: if you want, a lot of these images are available online in a lot of articles. So TB vasculitis, there's already one article which has been published by our group with me, Dr. Soumya Basu, and others as authors, where you will be able to get some of these images. The same holds true for AR and acute retinal necrosis. We have published some of these. So a lot of these images are already available online. You do not necessarily have to resort to me. You can easily get them from those articles also.
Okay, sir.
And those are in open domain.
Sure, sir. Sure. Thank you, sir.
And also you can review this session on YouTube. So there you can
okay.
review these images.
Yeah. Okay. Yeah, Iris has one question before we sign off. Yes, Iris, please tell me.
Sir, one thing I'm having in the books, the two terms. The first one is retinochoroiditis and other one is chorioretinitis. Sir, so these two terms interchangeable or they are different?
So they are, there are two ways of looking at it. They are not absolutely interchangeable. It basically shows what is the main nidus of infection. So usually you will see toxoplasma is a retinochoroiditis. That means it started in the retina. It has also involved the choroid. The main nidus is in the retina. See, none of our eye compartments are like foolproof. It's not as if you've got something in the choroid, it will not spread into retina or vice versa. But when you say retinochoroiditis, it means you predominantly have an inflammation in the retina, infection in the retina. It has also involved the choroid. When you say chorioretinitis, it's the other way around. It's in the choroid, it is now involved the retina. So tuberculosis ends up being a chorioretinitis. Toxoplasma ends up becoming a retinochoroiditis. You understand the point? Does that
Yes,
answer?
sir. Sir, but yes, sir, I understand, sir. But this is the theoretical way. But sir, I want to know when we are looking, the patient comes to us in the OPD, and we are looking at his fundus. Then at that moment, I am very confused. That is it either retinochoroiditis or chorioretinitis?
Again,
So I'm
if
very
it's
confused.
predominantly a retinitis which you are seeing, it is a retinochoroiditis. If you're seeing a choroiditis alone, then it's a chorioretinitis. Can I share one more image, Anuj?
Absolutely, sir.
That will help
It's
answer
your
the question.
forum.
Yeah, give me 1 second. Let me search for one image and see if I can show it to you.
Yes, sir.
I just need 1 minute. Let me see if I can.
Meanwhile, if someone has any doubts, you can catch up with Dr. Mudit because he's still available.
Actually, sir, I am from Pakistan, and I really like your videos, and I really like your lectures. I'm basically from Pakistan.
Oh,
Okay, that is nice. So your true name is Iris?
No, sir, my name is Mohammad Fahad.
Oh, okay, okay.
All right. So give me just 1 second. Let me just show you one image. So can you see this image over here?
Yes, sir.
See this one. Now you see this image over here. You see this is predominantly a retinitis lesion because this is superficial and you are able to basically not visualize the underlying blood vessels under this lesion. Can you see that?
Yes, sir. Fluffy region covering the
Fluffy
retina.
yellow
The
lesion
vessels are
covering the
obscured.
retina. You are not able to see the underlying. This is a retinitis lesion. Compared to that, see the other lesion. This is deeper and you are able to visualize the blood vessels which are passing over it.
Yes, sir. Yes, sir. Exactly.
So that is a choroiditis lesion. So when you see that, that is a choroiditis and that may have a chorioretinitis. When you see only retinal involvement, when you see retinitis, you will not be able to see the underlying blood vessels and it will be a superficial one. Okay?
Okay, sir. Okay, sir. Understood. Thanks a lot, sir.
All right. So somebody who is Redmi K20 Pro, I don't know who this is.
Can you introduce yourself and unmute and ask? I think maybe.
Redmi K20 Pro. Oh, they're here. Yeah. Who's this?
Hello, myself Dr. Arpit. I'm from Himachal Pradesh.
Yeah.
So, sir, I want to know about what is the probable diagnosis in this case?
The one which we have seen?
Yes, sir.
I have no clue. We'll have to investigate and find out. I have told you the differentials. I have told you the way forward. You will have to get those blood tests and everything done. And based on that, we'll be able to find out. What we have right now in terms of morphology is vasculitis. What is the underlying cause for that is something which we'll have to find out by doing those tests.
Okay, sir.
All right. Chalo. All right. Thank you so much, everyone. Good night and nice to join you. Thank you, Anuj.
Okay, sir. Okay. Good night, sir. Thanks a lot.
Yeah, good night.
Yeah.